an infarct to the optic nerve head, and so they can present to you with an optic nerve head that tends to look very, very pale. If you have a patient who complains to you of severe unilateral visual loss, it's very important to get them into treatment right away. For ophthalmologists to remember, and I think one of the concerns that also comes from a rheumatological standpoint is if someone is complaining of visual symptoms, you might say, well, let me delay treatment for this patient until they're seen by an ophthalmologist or a biopsy is done. Biopsies tend to be fine again if you've started treatment for giant cell arthritis up to almost 2 weeks. So you should never delay your treatment waiting to have this patient seen by an ophthalmologist. Please do start your treatment. It will never affect the outcome of the biopsy or what you can see on it. Individuals with giant cell arthritis can have 2 other presentations that are important to note. Occasionally you can get a cranial nerve palsy, so you can see in this patient that this eyelid is ptotic here. You can get a cranial nerve palsy where there is a loss of normal motility in the eye, and sometimes that can be a presenting feature in individuals. 10% of them will have a cranial nerve palsy. The image here on the left-hand side shows you a central retinal artery occlusion, which is non-embolic in nature, which is also seen in giant cell arthritis. So you can see that the retina is a little bit paler than what it appears to be over here, and this is what we call a cherry red spot. It doesn't appear to you to be very cherry red, and this is actually how it appears to us when we look inside the eye. It doesn't really have quite a cherry red appearance. It depends on the person's pigmentation, but this is what we call a cherry red spot. The other disease is myasthenia gravis that tends to present not uncommonly and which occurs at any age. In 75% of patients with myasthenia gravis, they tend to also present with ocular manifestations, and very often the ocular manifestation will be an intermittent, either unilateral or a bilateral ptosis. So you can see that the eyelid is coming down. The eyelid movements might be limited, and sometimes they might complain of diplopia or double vision only in one particular direction of gaze. 20% of these patients have only ocular manifestations, so it is important also for the ophthalmologist to realize that that is the only thing that is occurring and refer the patient appropriately to a colleague who is going to manage them. Another common disease that we all tend to see is sarcoid, which is granulomatous inflammation of many organs, including the eye itself. And ocular involvement tends to occur one time or another in almost a quarter of the patients. The most common ocular feature is granulomatous uveitis. So you're looking here at the cornea, which appears to you to be gray, and you can see all of these spots here, which are what we call mutton fat chromatic precipitates. These are deposits of cells on the endothelium or the inner side of the cornea, but this is essentially how they appear. Now, you can have them in a very localized area. They can be fairly small or fairly large. There are several anterior segment manifestations of sarcoid. You can see a chronic uveitis. You can additionally see an acute uveitis that is very active at the time. You can also see lacrimal gland inflammation. There can be changes that can be present onto the conjunctiva of the eye, such as a follicular or flatullar conjunctivitis. And you can also see nodules that can be present on the surface of the eye. Interestingly, if there are nodules that are present, these are very useful for biopsy purposes to help with the diagnosis of the disease. The image over here shows you again a patient with sarcoidosis with nodules that are present on the iris. You can see that the nodules can either be peripheral or they can be central right here at the pupillary rough. Individuals with sarcoid can also have deeper eye problems such as choroiditis and retinal vasculitis. So if you're looking here at these images, you can get an appreciation that the blood vessels don't really look absolutely clean. They seem to be somewhat interrupted. This problem tends to very often be segmental, and you get changes or infiltrates around the venous circulation, and you can tell what the venous circulation is in the eye by looking at the oxygen in the blood, which tends to appear darker. So the blood vessels appear to be looking the same, but you can tell which ones they are. We call these candlewax drippings. Also, the optic nerve again can be involved in sarcoid, and this tends to occur far more often in patients who have other involved CNS disease. You can also tend to see dyskidemia, and you can see granulomas of the optic nerve. The treatment for ocular sarcoidosis is similar to systemic disease, and you can use topical injectable or systemic corticosteroids or other immunosuppressants. Of course, there are other connective tissue diseases associated with ocular inflammation, such as Reuters, Behçet's, and Leschner's. And sometimes you might just find a patient with Behçet's where all that you find inside the eye is a sterile hypopion or a layering of white blood cells, and the eye again looks pretty deceptively quiet, but you have something going on here that needs to be managed. Thyroid is another common problem that we all see, and I wanted to talk to you just a little bit about that. Ocular abnormalities are very common in the thyroid. between the systemic symptoms of thyroid disease and also the ocular manifestations. So sometimes you can have a euthyroid state and you can still have thyroid ophthalmopathy, and it can continue to progress even after the baseline thyroid problem has been treated. It's not important to realize that there are several different ways in which this is graded. This is how the American Thyroid Association grades ocular involvement, but it is important to realize some of the obvious manifestations. You can certainly see that there is lid retraction here and exposure of the eye. This causes a severe dry eye, and eventually the muscles begin to get involved here where the person is trying to look up, and obviously there's a mismatch in the appearance of the eyes. Left uncontrolled, this disease finally progresses to severe involvement of the orbit, where you have proptosis and you have severe exposure and sight loss. At this particular stage, because you have so much infiltration of the tissue, you have a lot of compression around the optic nerve, and this causes visual loss to the patient, and it's very important to stop these patients from going through this process. And the way that is done is that if you get a patient into appropriate treatment, you can give them corticosteroids, you can give them orbital radiation, and you can give them appropriate surgery so they never get to this point of very often irreversible disease. And I think that that's really what I have in the presentation for you. I hope it's been useful in some way.